Welcome, bienvenue, Annie. My name is Nathalie Desrosiers, and I'm the principal of Massey College. And it's my great pleasure to have you here for a great event today. I'm so excited about this. I think you will see shortly why it's such an important conversation to have at this time. So I want to first acknowledge that Massey College and the George Ignatieff Theatre are built in Indigenous lands, the lands of the Yonwandut, the Seneca, the Haudenosaunee, and it is the treaty land of the Mississaugas of the Credit. I want to acknowledge our duty of stewardship toward this land and the great privilege that we have to continue to do our work here. So let me say a little bit the reasons why Massey College is so interested in this conversation. First of all, I want to welcome not only the people that are here, but also our audience who are watching us on our Massey College YouTube channel. So please subscribe. So Massey is a place of interdisciplinarity. It's a place where people and ideas intersect. And our mission is to nurture learning and to serve the public good. What more can you say? To serve the public good must mean that we pay attention to the real crises that are facing our society. And today we're going to talk about one of them. So we aim to raise awareness about among the people from the Massey community, but also more broader, about the specific options to improve and reform healthcare delivery. I want to say I'm very grateful to the panelists that are here today, and particularly grateful to Dr. Ann Golden, who will be leading the way today and be our moderator. She put together this exceptional program and this wonderful panel, so I want to thank her particularly for her great service. You probably all know Dr. Golden. She served as president and CEO of the Conference Board of Canada, one of the country's foremost independent, non-profit applied research organization. Prior to that, she was president of the United Way of Greater Toronto for 14 years. She earned national profile as a work as chair of the Homelessness Action Task Force, the Greater Toronto Area Task Force, and more recently, the Premier of Ontario Transit Investment Strategy Advisors. So she is a member of the Order of Canada, of the Order of Ontario, and she has received 8 honorary doctorates, and she's a wonderful moderator. So without further ado, thank you very much, Dr. Golden.
Merci beaucoup, Natalie, and welcome everyone. The origin for this forum goes back to the 10-part series called How to Fix Healthcare. It was in the Globe and Mail last spring, and some of you may have seen it. It focused on the changes that we can make now to start to fix Canada's and Ontario's healthcare systems. Over the past few months, we have seen a spate of warnings urging political leaders and policymakers to make major changes to how healthcare is delivered. Frontline doctors and nurses are sounding the alarm on a daily basis. We've all heard stories of dissatisfaction and frustration with Canadian healthcare. And to be honest, my friends, people in my generation are afraid to get sick. The case for change could not be more compelling. Canada, with among the very fewest hospital beds per capita in the G20 or the OECD, was already in a vulnerable situation before the pandemic hit. Now, the crisis is not just about beds, it's staff shortages. It's not just about care for adults. Ontario's pediatric ICUs and wards are over capacity, and you've probably seen the articles just this week. And it's not just hospitals. It's home care, primary care, long-term care, and escalating gridlock everywhere. Our entire healthcare system appears to be on life support. The responses to date have been, if I can say, pretty feeble. Some blame the pandemic, but Canada entered the pandemic with 0 unused hospital capacity and long wait lists. Some say we need to introduce more privatization, but analysis of private healthcare models does not support this as the solution. Canada's premiers blame Ottawa for not boosting federal funding, and you've probably seen the last day or two that they've now come to a stalemate. Ontario's Minister of Health has said the problem is long-standing and complicated, and that there are hence no quick fixes. The problem with all of these answers is that we are being asked to accept inferior health care as the new normal. But those who know there are solutions. Our expert panel today, and I'm so grateful to them, 3 outstanding leaders in healthcare in this country, are convinced that there are changes we can make now and that will have speedy positive benefits. I come to this as an informed consumer. As a 2-time breast cancer survivor and as the wife of a husband who lost a 3-year battle with lung cancer, I have experienced, just as many of you have, agonizing waits for appointments, the current practice of hallway medicine, and witnessed firsthand a system under significant stress. My professional background is history, and if I were asked to sum up what I learned in 10 years of studying history in one single sentence, it would be this: change occurs when the climate of opinion changes. Our goal today is to contribute to this needed change in the public's expectations of our healthcare services. COVID exposed the deep weaknesses of our healthcare system. The daily stories told in the media are creating a new narrative about healthcare in Canada, about emergency room closures, critical staff shortages, doctor and nurse burnout, intolerable wait times, patients dying without being seen by a doctor, millions of Canadians without a family doctor and no access to health care outside of an emergency room or a walk-in clinic. We're seeking to galvanize pressure for action, not simply to add to the litany of complaints, but to convince people that it does not need to be this way. We must change expectations among the public so that we don't accept poor performance and perpetual crises as normal. That is my big fear, that we're normalizing this. We can make changes now that will have immediate and longer-term benefits. We can influence the decision makers, both the politicians and bureaucrats at Queen's Park, to take action now. And our panel of experts could not be better suited to this task. I'm going to introduce them in the order in which they'll be speaking. First, closest to me, Dr. Alan Drummond, who apparently brought his own cheering section. You may recognize Dr. Drummond because he is the cover story of Maclean's this month. And, and honestly, I encourage you to read it. It's a fantastic article. And it's devoted, this month's Maclean's is devoted to Canada's urgent care crisis. Alan has worked as an ER physician at Great War Memorial Hospital in Perth, Ontario, for 39 years, which he describes as being a microcosm of Canada's 890 ERs. Or is that across Ontario, Alan, or Canada? Canada. He is a clinical assistant professor in family medicine at both the University of Toronto and Queen's. He has served as president of the Canadian Association of Emergency Physicians and chair of the Emergency Medicine section of the Ontario Medical Association. Most relevant for us today is that for the past 21 years, Alan has been public affairs co-chair of the Canadian Association of Emergency Physicians. This is the association in Canada for all emergency doctors, and he is the leading advocate in this country. There is no one who can speak more knowledgeably and more passionately about the emergency care health crisis in our country and province than Alan. Our second speaker is Shirley Sharkey. Shirley Sharkey is a foremost Canadian expert on home care and healthy aging. As a registered nurse and the longtime CEO of St. Elizabeth Health, she has dedicated her career to empowering people, championing compassion, and advancing innovation to change how people live and age at home. In May, just this past year, Shirley stepped down from that organization following 30 years of what her colleagues describe as breakthrough leadership. And in 2020, Shirley co-authored The Future of Aging, a book described, again by colleagues, as a brilliant and powerful challenge to locked-in ageist mindsets, policies, and service models. Shirley serves as Senior Fellow at the C.D. Howe Institute and is committed to public service through her leadership and involvement on many boards, including the UHN. Our third speaker, probably known to everyone here, is Dr. Robert Bell. Dr. Bob Bell served as Ontario's Deputy Minister of Health from 2014 to 2018. Prior to this role, he was President and CEO of the University Health Network for 9 years. And he was previously the Chief Operating Officer at Princess Margaret Hospital, Chair of Cancer Care Ontario, and a host of other institutions. Today, Bob advises a number of private and public organizations and sits on a number of not-for-profit and boards and corporate boards. He has published 2 novels. He has launched a third this fall, and I am going to say that I've read actually his other books too, but this book, Jonah Kay, is great, and I can recommend it enthusiastically for all your holiday gift giving. Just a little plug, and all the proceeds benefit the Indigenous Health Program at UHN. I have just learned that Bob, who I see as kind of a Renaissance guy, is now writing a 4th novel, in addition to everything else that he does, and I don't know how he does it. Bob was the primary author of that Globe series that I mentioned earlier. There is simply no one more knowledgeable about Ontario healthcare, its problems, and possible solutions than Dr. Bob Bell. I now invite Alan to the podium, and I invite the rest of you to listen in.
Thank you.
Thank you.
Thank you for the kind words. I'm just going to remove my mask, if that's okay. Is that okay? I'm not going to be sanctioned by anybody. Thank you. Thanks for having me here. It's a great pleasure, a great honor, actually. I'd like to welcome my cheering section that I brought along last night, who proudly displayed a copy of the Maclean's article to the staff at the Restaurante Bleu and got me a free tiramisu, so I really appreciated that. I work at the Great War Memorial Hospital in Perth, Ontario, which is the ancestral home of the Drummond clan, curiously. It is a town of 6,000 people. It is a broader population of 25,000 hardworking Canadians. Curiously, the town has more than its share of Juno Award-winning musicians, authors, poets, artists. I don't know what I'm doing there, actually, because I prefer to wonder what the local hockey team is doing. But it's a great little hospital, and I've been there since 1983, so yeah, close to 39 years. I have had a full spectrum of practice, both being a family physician, certainly an emergency physician, coroner, anesthetist, and I also practiced obstetrics. But my passion has been emergency medicine, and I have been in a leadership role in emergency medicine in this country since 1987 in one form or another. The Maclean's article was painful to be involved with, actually. It involved a lot of bearing one's soul and feeling quite vulnerable. I still feel quite vulnerable about it actually right now, and I feel kind of somewhat embarrassed to talk about it. But the essence of the thing is that throughout my entire emergency medicine career, I have viewed my experience at the Great War Memorial Emergency Department as a microcosm of what happens within the broader healthcare system. And that viewpoint has stood me in good stead over the years. We have the same problems as city hospitals. We are crowded. We are faced with violence. We are faced with inequity. We are faced with staffing shortages. And the article sort of basically points out how over the last few years, what I thought was an exceptional service was allowed to be denigrated into a barely adequate one. And I think what is true, I've received a lot of comments from my emergency medicine and emergency nursing colleagues across the country, because what they say is what we read in that article is what we're feeling every day. And so thank you so much for talking about it. To quote Sir Brian Goldman, I feel like have been on the other side of the gurney from time to time. I am the proud father of triplet children. And so as a young man, as a young doctor, I got to witness what healthcare could be like as a patient or as an advocate for a patient. I witnessed my wife's multiple pregnancy, her battle with preeclampsia, my children's prematurity. They were born at 29 weeks and spent an incredible amount of time in the neonatal intensive care unit. And so I got a sense of what it was like to be a patient. More sort of currently, I've now got this experience of these grown people in my life. My daughter, the cheering section, is an occupational therapist in an access center in Toronto. And not infrequently, I get to hear about the challenges she faces in trying to meet the demands of patients to keep them in their home with the inadequate resources provided by the government. So I get to hear about that. I do have a medical office. My wife works in that medical office. And daily she gets to hear the frustrations and the anger and the upset by patients who are being denied access to care that they deserve. In the old days, the good old days, we used to be able to make a referral, second opinion, third opinion. Now we're lucky if we get a first opinion after writing 8 or 9 letters of consultation request. And then usually it's an acceptance to see somebody by Zoom meeting about a year from now. So she gets the brunt of it. I have a middle-aged senior citizen population, and they are now flipping her the finger on an almost daily basis because they're upset with healthcare. Lastly, my daughter Hillary, who died of breast cancer almost 7 years ago, having been diagnosed at age 23, just before she graduated from Brock University, taught me a lot, I think, about healthcare in our province and in our country, and we got to see in some cases, the very best of medicine and the very best of medical care, and in some cases, the absolute worst. That left a very strong impression with me personally to rededicate myself to being the best that I could be and making sure that every patient in front of me, that they understood that I was going to be their navigator and their ally, trying to get through a very difficult system. This is perhaps one of the most damning indictments of our management of healthcare that I can think of. And I have a multifaceted practice, but emergency medicine is where I'm at. This is an article from the Globe and Mail, 1999, talking about how emergency rooms are a symptom of a much broader problem, and they are. But this is 1999, and this is 2022, and nothing has really changed. So we still have, inequities in access. We still have people with no place else to turn but that beacon of light that is the emergency department in practically every community in this country. We have, people that, there is no place for them to go other than to our doors, and we are frequently quite crowded. 23 years since this article was published, and nothing has changed. This is a painting from a Spanish painter whose name this one escapes me. I think it was Perez. Yeah, it was Perez. Who, having taken his granddaughter to an emergency department in the States, decided that he would, paint that experience. And it's a dystopian view of emergency medicine, but it is an accurate view of emergency medicine, with the physicians towering over, the huddled masses. Naked and desolate, the vulture sitting on the side waiting to pick off the stragglers and the strays, the policeman directing traffic, and the ever-present TV cameras willing for a very brief time to shine a light on the problems. It struck me as funny when Elizabeth Whitmer was the health minister and in 1999 described it was a mystery to her why emergency departments were so crowded and so dysfunctional, because it was very clear to us what the problem was. And thankfully, around the late 1990s, after there was a drastic bed reduction across the board in Canada and in Ontario, in order to sort of balance the budget, courtesy of Paul Martin's federal initiatives, we saw about a 30% reduction in bed capacity across the board. At that time, Canadian emergency thought leaders, such as Michael Schull, such as Grant Innes in Calgary, such as Brian Rowe in Edmonton, started putting their heads around the issue of why are we crowded and what impact is that having on our patients. And so it really wasn't a mystery, it was defined for us. Mel Lastman, who was the former mayor of Toronto, having spent an evening in the Toronto General, decided that he would encapsulate the views of most provincial governments in this country by declaring that, in fact, There were a lot of people in that emergency department who shouldn't have been there, and that was the cause of crowding. We had too many people inappropriately overutilizing the emergency department, and it was all down to patient abuse. And I can tell you to this day that thought remains, that mythology of the basis of crowding remains pretty strong in many provincial jurisdictions, including Quebec, Manitoba, and British Columbia, where the strategy has always been for the last 20 years, let's blame and shame the patients for showing up, and let's try and divert them to somewhere else, but let's not address the issue of bed capacity and system capacity. So a number of years ago, the Globe came out with an article around Christmas time where even Jesus was turned away from an emergency department because there was no room at the inn. And I thought that was a very apt description of what was causing our problem. And so I wrote a paper called No Room at the Inn, which looked at the whole issue of the causes, the root causes, the problems associated with crowding, and the potential solutions. But like all good papers, and may I say that this was a good paper, it went nowhere with a bullet. We have looked as a specialty on numerous occasions now trying to define for our political leaders the problems associated with crowding and the root causes and the solutions. CAPE, the National Specialty Society, wrote 3 position papers in the early part of the century. Bob Bell and I, in a tripartite meeting with both the OHA, the MOH, and the Ontario Hospital Association, looked at the issue of crowding. We had Michael Schull as one of our leads, and the emphasis was pretty clear. What's happening in the emergency department is really not a problem of the emergency department. It's a problem of the system. It's a reflection of system capacity, of boarded patients in the emergency department because there are no beds available in the hospital setting, and there are no hospital beds available because there's no long-term care that's meaningful, and home care is a sham. And that was the thrust of the thing. We can define it for you, but at the end of the day, if there's one take-home message from this study or this paper, it is that we, in order to improve crowding, we need to look at system capacity both in the hospital and beyond. There are problems currently facing, as Anne mentioned, emergency services in the province. Crowding is ever present, and it doesn't look like it's going away anytime soon. I had the unpleasant experience of witnessing a closure of our emergency department for 3 solid weeks this past summer, the busiest time of our year as cottagers sort of, flock to our lake regions. And there hasn't been, I used to be very proud of Ontario. While places like Nova Scotia and Prince Edward Island and the interior British Columbia struggled with closures continuously, Ontario never had an emergency department closed in over 15 years until this past 2 years, and more notably during this past summer, where about 17 or 18 emergency departments, including Le Montfort, a suburban hospital east end of Ottawa, had to close because of staffing shortages. So, it's kind of disconcerting when our minister says, crisis, what crisis, when every one of us on the ground recognizes that indeed there is a crisis. The other problem that we've noticed is that our nursing colleagues are tired, they're burnt out, they're fed up with being disrespected, they are fed up with not being listened to, but more importantly, what they are really fed up with is that they are unable to provide the safe level of quality care that their patients deserve. And so when they squawk and bitch and whine, they are not doing any of those things because their vacation has been canceled or because they're forced to work overtime. It's because they are facing the moral injury of being unable to provide quality care when patients most need it. Now, the issue of staffing shortages in nursing also affects physicians. CAPE did a study about 4 or 5 years ago that said that by 2025 we'll be 1,500 emergency physicians short. 1,500 emergency physicians with no plan in this country or in this province to address that shortfall. And physicians, like nurses, are burning out and they are leaving. And this is not politics 101, this is not fear-mongering, this is just the reality of it. In our emergency department, we went from 15 nurses to 7, not because of COVID, but because they felt that they just weren't able to do the job that they were trained to do. It was becoming a de facto ward, and a very bad ward at that. So those are the 4 major problems that are facing us. But the biggest problem, that I think doesn't get the attention it deserves is that of so-called hallway medicine, which is no medicine at all. We see the TV cameras focusing on the congested waiting rooms, the 20 hours where the sick child waiting at CHIO to be seen, the ambulances being sort of stuck in hallways and unable to respond to community emergencies. We all get that. But what we don't get, because we never get to see it, unless we're part of it, unless our family is parked in the hallway, is what happens here. This is what is so-called hallway medicine, which is where we take those people who built our country, who spent their lives, building a great nation that we are, paid their taxes on the expectation that Medicare was their birthright and would be there for them. And what do? We park them in a noisy, brightly lit hallway where there is no privacy, there is no toileting facilities, their basic human needs aren't met, such as toileting and nutrition. They are delayed access to vital therapies such as antibiotics. It is disgraceful. And yet it happens every day in every emergency department in this country, and nobody says a word. Furthermore, if the moral decay associated with this wasn't evident, then there are other issues that impact the healthcare situation. We know that people who spend an extended period of time boarded in the emergency department end up having a higher mortality rate. They die more often. And the longer they stay in the emergency department, the greater that rate of unacceptable and avoidable mortality increases. This past summer, I have a 9-stretcher emergency department. I came back from vacation, all 9 stretchers were occupied by admitted patients, and they were there for days. Before I came down here this weekend, I had a cancer patient who's dying, and she spent 2 days in our emergency department being palliated in an orthopedic room. There are also costs to the system. We know that people that spend extended time being boarded in an emergency department actually end up increasing the length of stay in hospital and increase hospital costs. So, we've done our best. I'm tired, frankly. I'm tired of mitigating. I'm tired of all the strategies emergency physicians and nurses do to try and make this system work. I'm tired of it. I'm tired of rapid assessment zones. I'm tired of examining people in closets. I'm tired of talking to people in hallways about their STD. I'm tired of it all. I can no longer go to an academic meeting and hear my colleagues talk about how they can shave off another few minutes off a visit by doing X, Y, or Z. They're mitigation strategies. If we want to solve this, it has to be political. There's no getting around it now. It's time. Our premier he's now a second-term premier. He likes to blame Dalton McGuinty and thank you much. So he likes to blame them every time and at every opportunity. Although I would say that Dalton McGuinty was the first and only premier in this country to make emergency department wait times a priority for his government. So kudos to him. And I'm a conservative. But he promised in his first term to end hallway healthcare. Well, how did he do that? Well, he didn't invite one emergency physician or one emergency nurse to the party. Ended up with a bunch of people recommending pill-pushing robots, and that was somehow going to solve the problem. He also promised to cut hospital wait times. Well, you haven't done it, and we've done our best. We are doing bedside ultrasound, point-of-care laboratory testing. We are seeing people in unconventional spaces. We're doing our bit. All you have to do, Premier, is read the literature. She promised to keep emergency departments open, while saying that it was inappropriate to call the situation of 17 emergency department closures inappropriate. If you want to keep emergency departments open, then you have to keep nurses working. And so I don't know the politics of the bill C-124. Yes, it's a financial bill, but for them, it's inflammatory and signifies this total lack of disrespect. But again, for most of the nurses I know, it's not a monetary issue. It's a quality of care issue. And I have missed a slide. Yeah, okay, so here it is. Things have to change. the ambulances that pile up outside our emergency department, the patients that are on ambulance gurneys in our hallways, the patients lying around for days on end, the people in this slide, my mother, my father, your uncle, your aunt, your sister, your brother, my daughter, and we did spend a day in a hallway at the Ottawa General. It's not acceptable. It's time for things to change. Thanks so much.
Hi, everybody. It's so nice to see some familiar faces. I'm delighted to be here to really talk about this very important issue and to really give you what I think are some solutions and some positive hope. Having worked in home and community care for 30 years, and it's an area that I absolutely loved, but also working 10 years in a teaching hospital, but also being a visiting nurse, brings a perspective that is very wide about how people live their lives and how they experience healthcare living their lives. So let me start by saying, yes, unfortunately, right now we do have a perfect storm. This storm has been created by decades of short-term decisions, not really analyzing the long-term issues and planning that we need to entertain, and the continuation of continuing these short-sighted solutions. The pattern of continuing to do the same thing over and over again certainly brings the same problems, which we've heard about. Hallway healthcare, wait times, ED backlog, ALC. I could not believe yesterday on 680 News, I thought, oh, apropos to my conversation. What comes around keeps coming around. Now, in February 2020, I remember I was at the airport, enormously frustrated that I didn't feel we were getting any momentum with really reorientating the health system to be about keeping people in their homes and in their communities. And I likened this kind of time loop of continuing to do the same thing to the movie The Groundhog Day. Bill Murray, if you haven't seen it, was TV weatherman. And he gets locked into this time loop where he keeps waking up the same day every day with the alarm, getting out of bed, stepping on the sidewalk, and on this puddle. And I remember saying, oh boy, I can relate to that reality. How do we get out of this loop and change things and have a more effective long-term plan to understand the future and where the population is changing, where our health experiences are changing. And yes, we have to deal with the crisis of today, but we need a roadmap that will position us for the future. And we're way behind on that. And it's not because we didn't have warnings and reports. It's been very hard to get home and community care anywhere on the map for a lot of different reasons. But when I first started back in the 90s, we had the National Conference on Home Care in 1998, and I need to tell you, I was so excited. Oh my gosh, I was dancing on the stage. This is the time to realize it is about care for people in their homes. 1998, crickets. 2002, with the Romano report, again, absolute clear perspective that we had to reorientate the system and look at how people were living their lives in their homes and in their communities. How do we keep them there? Give them more options. How do we get everybody off the highway of hospitals and get some of those ramps so that they can live the lives the way they want and age in the best way possible? Fast forward. We have had the most comprehensive and deep reports to tell us about the care needs of people, where, when, how, and why we should be dealing with them in a whole variety of different ways. How we can reduce average length of stay, how we can reduce people even going to the emerge department, how we can change up this trajectory that when you turn 65, you have nothing to be worried about because you will have access to a long-term care institutional bed. Isn't that great? This has to change up. We also had Andre Picard and his book, Neglect No More, with COVID. I thought that would help people realize that there's a problem with how we continue to move ALC and push them out into long-term institutions. And we have a real understanding of what are the care needs for people in the community, what they require, what triggers the need for institutionalization. And do you know more than anything, where someone is assessed and who they are assessed by, there's a 6-time chance that they will definitely go to long-term care and an institution when they're assessed in the hospital. No surprise. And it really can't be faulted because that's the reality of the acute care world. They're assessed in a different setting. There's much greater likelihood that people will say, let's give this a chance. Let's have mom go to her home where she wants to be in the first place. So, what do we do? Well, suppose we note, and we certainly have, what other countries are doing. Denmark, the Netherlands, Finland, Australia, Japan. And why they have been able to come up with a whole change in their health system over the years, over decades, and really have certainly a higher population of older people than we have a lower cost per capita, and they also have, in fact, better outcomes. So what are they doing differently? What's happening? And when I toured Denmark and Netherlands and Australia, I was so mesmerized and inspired by many of the things that they were doing, where they really were creating a robust community and home care environment in so many ways. But then I started to think, in Canada, we have the same competency. We have the same brilliance. We have the same passion. So what's going on here? And I thought, well, maybe rather than spend 3 decades undervaluing how older people are living in their homes and in their communities, what these countries did was had an amazing vision. And that vision was to have a country where people live well and age well. As simple as that, and as complicated as that. So it did really lead me to believe how much of this is all about ageism, how much of this is all about ageist policy and direction. And do we really need to unravel that and give more voice? A real shout out to National Institute of Aging that recently has been giving this a voice and bringing all of us into the conversation. There are other initiatives. There's a Courage Summit coming up in December to again begin to address this issue, which is far greater than the healthcare system, but society at large. So, what happens now? What do we need to do? The good news is it's taken us so long to make any changes. We're actually very brilliant and know what needs to be done. We have experts that have a very good understanding of what needs to change from a policy point of view, a legislative point of view, and a funding point of view. The community has the know-how, and please listen to this message because there's a subtle message underneath it. The community has the know-how. Many people feel they don't. but it's because they've not been legitimized, nor have they been funded effectively. So we need to scale up those initiatives, create these robust systems, and work effectively with all of the other parts of our system. We need to understand that long-term care is not about beds. Just like the whole system, if our starting point is how do we free up acute care beds, as we know, we'll never get out of that. Long-term care is a concept that actually crosses all of the sectors. But it certainly in Canada has continued to be viewed as beds and institutional care. And I'll just quote from you how this is played out from a funding point of view with Drummond and Sinclair's report, Aging Well. The measly 0.2% of GDP Canada spends on home care is one of the lowest allocations in home care in the OECD countries. Even worse than that is the ratio of more than $6 spent on institutional care for every dollar spent on home care. It's one of the most imbalanced resource allocations in the developed world. Now let's think about this for a minute. 96% of the population actually want to remain in their home and are open to all sorts of different options. Actually, I was surprised only 90% of people over 75 are actually in residential and institutional care. Let's just think about how this funding is imbalanced, even the small amount that exists for long-term care in general. We've in fact made home care be the first stop, the first support in the upstream. So, in conclusion, so who's going to do all of this stuff? Everybody. But let me just work that through. All levels of government, certainly the federal government, we know all about the Medicare 60 years needs to be modernized, the preoccupation with acute care services. Provinces need to reorientate their system and deal with really creating home and community environment. Where I have the most hope is municipalities. I think they're going to be able to help us with housing and home care in a whole new way of doing things. Another important area are health professionals. We have to stop valuing a health professional based on where they work. Stop valuing that a health professional is better in the acute care hospital system, and everyone else is a second-class citizen. Because what that actually is saying is that patients in the hospital are valued differently than patients and people in society. That has to stop. Lastly, and most importantly, to really deal with what I believe is more of an ageism problem, all of us, the community, the people, need to speak up and need to continue to reinforce the changes that are necessary and to really call out ageist policies and things that are just not good for society and just not good for our healthcare system. So, Canada can become a country, the best country, where people can live and age well. But boy, oh boy, we all better giddy up and get moving with the action. Thank you.
Principal DeRosier, Dr. Golden, thank you so much for the invitation today. Delighted to be here, especially to join Alan and Shirley. What terrific people to tell us about Canadian healthcare. You know, how good is our healthcare system? How do we rank internationally? Well, unfortunately, if you look at 11 wealthy countries in the world that the Commonwealth Fund evaluates on a regular basis, we're 10 out of 11, even before the pandemic, even before this recent crisis. And cause for that, the biggest single cause is access, how we get to see folks. Our system is based on primary care, right? You can't go anywhere without primary care. You can't get a lab test, you can't get an x-ray, you can't see a specialist. You need to have a primary care provider. How many people in this room, God forbid, if you get sick tomorrow, if you have a fever, if you have burning when you urinate, how many of you can see your primary care doctor, do you think, within the next 48 hours? Put up your hand. Well, you're a very lucky audience. Let me tell you what Angus Reid found in their polling of 2,000 Canadians reported on September 8th. Half of 2,000 Canadians polled either do not have a primary care provider present or cannot get an appointment to see their primary care provider within a week. In more detail, 20% reported they didn't have a family doc, 85% of whom were looking without success. Of the 80% who had a family doc, 14% were satisfied with their access. 33% said access needed to be better, and 33% said it totally sucked. Angus Reid also reported that 36% of Americans say it's easy to get an appointment compared to 14% of Canadians, and 70% of Americans said that access to their doctor was acceptable as opposed to 30% of Canadians. So that's a recent poll that I think suggests that access to primary care in this country is pretty dramatically worse than it used to be, and it's probably declining. And some of that is undoubtedly the impact of the pandemic, the impact of the difficulty of providing primary care in a pandemic, but also part of it is related to the fact that medical associations across this country have sold Canadians a bill of goods. They've told us that every Canadian needs a primary care doctor. You've all heard that. It's not true. Every Canadian needs a primary care provider. And in most places in the world, that provider is not necessarily a doctor, right? International comparative studies, randomized trials putting people who are sick into a primary care doctor or a primary care nurse practitioner's office see equivalent outcomes 2 years later. But primary care nurse practitioners in this country serve pretty much mainly as assistants to doctors, not providing care at full scope of practice, even though regulation allows them to. In Ontario, there are 26 nurse practitioner-led clinics where nurse practitioners provide rostered care to patients, the same as family docs in the office, and those patients are highly, highly satisfied with the care they're receiving. Now, that doesn't mean that there's no role for family docs. Some patients require physician care, more complex patients, but teams based on all providers, nurse practitioners, physiotherapists, mental health specialists, as well as physicians working to full scope of practice could dramatically expand primary care capacity quickly. It takes 2 years to take a nurse, a registered nurse, and train them to be a primary care nurse practitioner. 6 years to train a family doctor. Medical associations are telling us that we're not going to have enough family doctors. They're going to be retiring. Why aren't they also telling us, for goodness sake, we're not going to have enough. We need other people to provide care. We need nurse practitioners. They're starting to say that. It's a bit too late, but we desperately need to accept the fact that nurses can be primary care providers and start training them and giving them the opportunity to do that, because believe me, nurses love that job. And it's a tough job for them to get into right now because they can't get paid. Because all the money that's being provided for primary care in this country basically goes to doctors. It's not fungible. That needs to change. That's the first thing that needs to change. The second piece of access that Canadians have trouble getting to is specialists, right? And part of the reason why people end up in emergency departments is because they can't see a specialist. And they think, well, the fastest way for me to see a specialist is to go to the emergency department. Well, you know, a lot of studies have demonstrated that you can reduce wait times to see a specialist by 20%, simply by ensuring that each referral goes to the specialist with the shortest wait list. Makes sense. When you're referring a patient to see a cardiologist, which cardiologist do you know? Probably the cardiologist who's been in the community for the longest period of time has got the longest wait list. Whereas if you send an electronic referral that routes the patient's referral to the person with the shortest wait list, you immediately, without spending a penny extra, reduce wait times by 20%. Not only do you reduce wait times, but you know that story of, well, I think my referral was faxed to the neurologist about my headache, but it's been 6 months and I haven't heard anything. I wonder if that fax got lost. Let me phone the neurologist. Oh, I can't get through. You know, it also tells the patient who's been referred with e-referral that their referral has arrived and that probably I'll see the specialist 2 months from now. Okay, at least I'm on the wait list. At least I know that the fax didn't get lost. And thirdly, a huge advantage of e-referral is it gives ministries information about where backlogs in the systems exist. I used to sit with deans of Ontario medical schools to talk about the distribution of residency specialties. How many residents in rheumatology versus cardiology versus hematology versus orthopedics? Where are we going to fund in the next year? And guess what data we relied on to make those decisions? None. Because we had no idea what the wait times were to see the vast majority of people who are specialists in our system. We knew the wait times it took for people to have surgery, but if you were referred to an orthopedic surgeon for your back pain and you didn't need surgery, your data disappears. There's no information about the amount of time it took you to get there. So, you know, this is an amazing potential positive for our system. Reduce wait times by 20%, tell people when they're going to see someone, and collect data on where backlogs in the system are. It must be very expensive. It must be something that's difficult to do. The answer is no, it's cheap, it's available, and it could be in place across the country today, but only about 20% of referrals are occurring because of the simple unwillingness to change. This is software that's paid for by ministries across the country. It could be on every primary care computer, every electronic medical record. It could be in every specialist's office. But until we say, as Anne suggests, we're sick and tired of prolonged wait times, we're not going to accept the inefficiency of not knowing whether your fax has been lost. Until citizens like yourselves say, we need e-referral today, we need it tomorrow, it ain't going to happen. We need to insist that it happens. Finally, I'm going to talk to you about a third solution that's a little more complex, but it relates to the issue that you've heard from Alan and Shirley, and that is people who are in our hospitals who no longer need to be there. We characterize them as alternate level of care patients, ALC patients, not their fault. The worst thing that can happen to you if you're a frail senior who's actually making it on their own independent in their home, the worst thing that can happen to you is you get admitted to hospital with a pneumonia or maybe a little worsening of your congestive heart failure. You're put in bed for a week. The lights are always on. You can't sleep. You're never really able to eat properly. And at the end of a week or 10 days, you may have suffered through an episode of delirium. The last thing you're ready to do, now that your pneumonia is better, is to go home. And what's the solution? Quite often people come around and they look at you lying in bed and say, long-term care. You're on the long-term care wait list, and based on the government's current position, we're going to send you somewhere where you don't even know where you're going. You don't have any choice about it, and you're going to be charged $400 a day if you don't go immediately. Well, you know, there's another solution. And the solution is something called transitional care. It's a place where you go, where you get physiotherapy that gets you up and walking and gets you ready to go back home. It re-energizes you. It builds back some of those muscles that you've lost during the course of 2 weeks in hospital. And the good thing about transitional care, it's not like long-term care where you're going to live out the rest of your life. It's not like acute care, hospital care, where you have to have facilities. You have to have labs, you have to have ORs, you can make do with residential facilities, you can make do with retirement homes, you can make do with long-term care homes where you don't want people to live forever, but for a period of time to try and get you ready to get back on your feet, you can go there for a couple of months. And the answer is, if you do go to transitional care, study after study shows that 30% of the people on the long-term care wait list end up going home with home care, but they end up going home. And you might say 30%, that's not much. Well, 30% is huge if you're one of those 3 people that no longer needs to go to long-term care. And it also makes a huge difference to the sustainability of our health system when you consider that it's $70,000 a year when someone goes to long-term care. Do we have solutions that are potential that we can put in place today to solve some of the worsening of the system? Yes. We can expand the definition of primary care. We can insist that every referral to a specialist in this country happens with a technique that reduces wait times by 20%. And we can insist that rather than spending 10 years to build new hospitals that get announced 42 times, Minister Matthews, during the time that 10 years have been spent, or spending 5 years to build new long-term care centers, which also take a long time. They're going to be people's residences forever. We can take every healthcare facility that's not being used and recruit the people who are essential to provide transitional care that can get them out of the hospitals that are preventing patients in Allen's emergency department from being admitted to bed. We do have solutions, and as Ann would tell us, it's time that we change our acceptance of substandard care and start thinking about care for the future. Thank you very much. Oh, wait. I can be a shameless huckster because every penny of Jonah K goes to the Indigenous Health Program. Go on Amazon or on my website, drbobbell.com, and order your Christmas list today.
Oh, I think this is on, right? Catherine? Sorry, oh, yes, sure, that's a good way. Okay. Oh, I'm supposed to be, okay. Well, let me try. Otherwise, can you hear me now? No. All right, can you all hear me? Yes. Perfect. Okay. Oh, that's right, online. Okay, this one. Yeah, okay, good. Thank you. Well, 3 passionate presentations, and I'm going to, because I want to get to some questions, first of all with us, I want you each to have a chance to comment, but I do want to, by 1:45, to have a few questions from the audience. I think some of you would like to ask a question. But I just want to ask one question to each of you. As I was listening, each of you said, first of all, there's absolute consensus that the system is not only flatlining, but it appears to be in kind of a downward spiral. Everybody here has painted a picture that is pretty tough. But we've heard answers. I'm going to start with you, Alan, Shirley, you talked about it being about ageism, but really you were talking about culture and values. And that resonated with me because as an historian, I believe that most of history is about culture, not economics. So, but I want to ask, so to your answer is empower the community, change the funding model, and get people to understand that people want to stay in, focus less on the institutional and the transactional model, and move people. Really, what was the Star did a whole set of articles last week, aging in your home. Bob, I'm very familiar with your thinking about this, but to you, it's expanding the whole concept of primary care through nurse practitioners and using the techniques of e-referral to get around the old way of doing it, have a centralized registry with shortest access to specialist care, and move into transitional care, focusing less on hospital beds. And even though we're, and then there's another one that you also wanted, was taking unnecessary surgeries that don't have to be done in hospital and taking them out. Yeah, ambulatory surgery centers. Your answer, Alan, is that it's the issues are political will, and funding. So how do we, and everybody is aware, because I sort of started that way, in terms of political priorities, everybody agreed that all 3 levels of government have to be involved, yet we're seeing a stalemate between the province and the federal level, even disagreeing on how much money is being transferred now, disagreeing on accountability. We're seeing, in terms of provincial priorities, the focus is on buildings, absolutely the opposite of what you're recommending. In terms of municipalities, because of what's happening also today, the Bill 23 and other bills, where municipalities will have less revenues, and you're seeing from AMO and other organizations that there's a real crisis now at the municipal level who have no flexibility to invest in creative solutions. Where do we go from here? Your answer partly, Shirley, was advocacy. I would ask each of you now to say, if you were the Deputy Minister of Health, if you were again, Bob, Deputy Minister of Health, just for a short time, what would you do? How would you start turning this ship around? Alan.
I do flat lines and death spirals every day of my life, so I'm pretty comfortable with that. I don't know if this is on or not. It is, thanks. So I'm pretty comfortable with that scenario, may I say. Look, we have a dysfunctional country. I mean, I'm an immigrant. I love this country. I'm glad that I'm here, but I do not understand how we can have, within the unique perspective of my issue, which is that of crowding and dysfunction, how we can see 10 different solutions applied to a common problem. I mean, this makes zero sense to me. I wouldn't want to be deputy minister. I would want to be king. So when I look at what happens in St. John's and in Montreal and in Saskatoon and in Vancouver, and I look at different provinces trying to spin their way out of a common set of problems with respect to crowding, to boarding, to system capacity, it just drives me crazy. And I understand this sort of issue in Canada of hands off for the federal government, even though the federal government still has a federal minister of health. So presumably they still have some sense that they have a role to play in national standards of care. So we did actually ask at one point the federal government to consider developing a national template for how to approach the issue of the boarded patient and to have a forum for, because Canada has some really gifted researchers in emergency medicine, like truly international superstars. We don't need to go to the Americans or the British for answers, or the Danes or the Australians. Like we've got the answers right here at home. And we asked for a national forum where we could elucidate common practical solutions to the boarded patient, and we got absolutely nowhere. So if I were king, I would ask for a greater say of the federal government in the administration and development of medical services, particularly emergency medical services in Canada. That would be my one wish.
Okay, well, I'm sort of with you, Alan, but I don't want to be king. I want to be the prime minister. And why do I want to be the Prime Minister? Because I think they set the stage of the values and culture of what this country is all about. And I think fundamentally we do need to understand as a society what's important and what we value. And it's very difficult within the healthcare system without that solid and landed that we don't get preoccupied. And if it wasn't so serious, I probably wouldn't joke about it, because I do think we have a new condition called bed-itis. Bob, I would challenge the woman who was admitted with pneumonia. I think you're right. Doesn't do a good job at all, and certainly activation centers are important. But I'd say, quite frankly, what the hell is she doing there in the first place? We could have taken care of her in the community. But we have to create a different starting point. And a starting point that's less about protecting our beds and our acute care system. And strangely enough, if the starting point is really anchoring care for people in their homes and in their communities, ironically, we actually will have greater access to the beds and to the acute care system. It's been proven in every single country. So I would bifurcate what needs to happen. Let's just say I don't make it to be Prime Minister and I actually am the Deputy Minister. I think we have to deal with the crisis of the day. It's very hard. There's a lot of noise to be talking about life and death and children and emergency rooms and a family member who doesn't get to see someone when it's a serious condition, and at the same time go, we really need to care about aging well in the community. Those conversations are difficult to have at the same time. So we need to deal with crisis management and intervention at this moment in time, yes. But what we've been lacking is this roadmap that will help us position for the future simultaneously and measure how the population is changing, how chronic disease is different, how with technology we can do things very differently. I mean, the best silver lining of COVID was we finally had telephone visits through home care be funded. Like, are you kidding me? Virtual care, you're absolutely right, Bob. Access, we can have access to health and information right now in a variety of different mediums and vehicles. So creating this roadmap for the future and sticking to it and evaluating it while at the same time deal with the crisis of today, both need to be happening. So I hope you vote for me the next election.
Can I just say, I like the idea of roadmap, and particularly with respect to rural emergency services, where it has come to pass that every small community believes that it is their right to have a full-service emergency department 24/7, regardless of, well, patient volume, usually, and it's impossible. This country is too big, and the resources are too small. And, you know, we need to start with that sort of concept of the paradigm of the roadmap, I think is exactly where we need to go, particularly from that perspective, which is, why don't we embrace our rurality, our geography of this mammoth country that we have, and decide going forward a template or a roadmap for how we apportion emergency services such that it doesn't necessarily imply that every community has a department, but that every Canadian has timely access to quality emergency care.
You know,
So I think that concept really resonates with me.
you know, and we've got examples. We've been very negative about the Canadian health system, but if you're going to get sick, make sure you're having a heart attack, all right? One thing we do really well is managed, would you agree, ST elevated MI? Across the country, we have decided roadmaps that if you're in Perth, you need to get really fast into a center that can put a stent in your heart. And it's not going to happen in Perth, but there's somewhere where if you come to the Perth Emergency Department, what's it called? I love the name of your emergency department.
Yeah, well,
What's it called?
It was
It's
named
called-
after there were about 25 30 soldiers from Perth who went to the First World War
Right.
and who died. So the hospital was named, after them in a memorial. But for them, it wasn't really a great war. It was just an okay war.
Okay.
That's a lame joke. I'm sorry.
Whenever I used to see funding lists for various hospitals, I was always careful to push yours up a bit because I love the name of your hospital, right? That's how government works, by the way, Names are important. Anyway, I'm the only one that actually can answer the question of how much fun would it be to be a deputy minister and actually solve something. And the answer is the best job in the world. It's an amazing job, especially in Ontario, because 14 million people is just about a perfect-sized health system to actually make a publicly funded system that works. The thing I didn't know when I started the job was what I thought didn't matter. It was what the Premier's office thought, right? And if you don't convince the Premier's office, there's no way in the world that you're going to be able to make any change at all. But if I was going to have that role and convince the Premier's office of one thing, it would be to fix primary care. Because, when you think about the encounters that you all have, fortunately, you probably may see an emergency department every 2 to 3 years, if you're reasonably healthy. You rarely see a specialist, but you'll all see your primary care provider in the next couple of years. And primary care is essential to the Canadian health system. We formulate our system, not like in the States where you refer yourself to an orthopedic surgeon if your insurance will pay. Everything here is dependent on a well-structured primary care system. We've allowed our primary care system to be run at the labor management table as opposed to at the policy planning table. We need to take it off the labor management, and the best way to do that is to bring other people into primary care who aren't represented at the labor management table. So that's what I would do simply. I would focus on primary care. And other stuff, people who, guess what? Who can't get to see their primary care doctor, guess where they go for their primary care? They go to Dr. Drummond, right? So.
Okay, but here's the other side. Okay, I thought we were all going to agree here today, but maybe not. So here's the other deal, though. I worry about this subliminal message that is just throughout the entire healthcare system that somehow seeking primary care alternative in the emergency department is somehow wrong, immoral, wasteful of resources. Let's be straight about that. We're open 24/7 without relatively non-urgent patients. Most rural departments on a funding mechanism would pack up their tent and go home. We function as essentially the alternative walk-in center for that we don't have in rural communities. And here's the other thing. These patients cause no problem for us. They don't. They require little in the way of physician time. They require little in the way of nursing time. They are resource poor. We don't end up spending a lot of money on technology or treatment. So, we're the beacon of light that's on in every community in this country.
The final common pathway.
And you know what? If you can't access another alternate care source, then come. Don't feel guilty, and don't let the politicians make you feel guilty.
Totally agree, but the sign of a failing primary care system is that more and more people end up getting primary care in emergency. It's not that it's inefficient, it's not that it's costly, I agree with you. It's not the best care, though. The best care is comprehensive care with a group that knows you and understands you and has access to your medical record, which you don't have.
Okay, well, just one question. So here's the other side of this, Bob. The reality is, being a consumer of healthcare, one-stop shopping. You can go and see your primary care physician, be referred however you like to see orthopedics, who will require an X-ray or whatever. You come to the emergency department. One-stop shopping. You bring your kid. You get your diagnostics. You get your lab. You get your X-rays. You get your assessment. You get your diagnosis, and you get your treatment, and you get it with a smile.
I'm just going to see if we only have about 10 minutes left. So I just wanted to see anybody who has a question, just come down to the mic, would you?
Why don't we bring a microphone to Camille?
Here, right here. Okay, and
Yep.
Camille has. Okay, I'll take my microphone.
A question.
Okay. So first, Camille, just over here, and then you. Okay.
This is a question from one of our online viewers. Bennett McCarty is asking, regarding short-term thinking by political decision makers, How exactly do the panelists think this can be overcome to achieve the changes you're recommending?
I don't think it can be changed quickly, and that was my point. I do think crisis management with where we are now probably does require some short-term thinking, but let's hope that it's smart short-term thinking. But that's where I was moving to. There has to simultaneously begin to communicate to the public where the roadmap to the future is. Or we continue this cycle of the same problems over and over and over again. And we continue that loop. So I do think it is a combination. It also is necessary to communicate that effectively about what we're doing today and simultaneously what we're doing tomorrow. You know, for example, and I just want to be careful that I don't step into this puddle, we could be really looking at the ALC problem and say, okay, short term, here are some options. I think what's been looked at is definitely problematic, but we could say, here are some short-term options, but concurrently, we're doing A, B, C, D, E, F, so we stop this cycle. And there needs to be courage, managing the noise, and effective communication to make that happen.
Just to ask any of you to answer this, COVID, if nothing else, taught us who the people are in this province that suffer, do not get care, do not get access, and is at the end of all of this. As we have this discussion, everybody here on the panel, everybody in this room, are not representative of those people. So as we go forward with the roadmap, etc., how do we make sure that when we talk about Canadians, we talk about a half of Canadians that's not represented in this room and is often missed in these kind of conversations?
Well, you know, one thing I'm pleased about is that I noticed Dr. Frank Martino is here, and he's going to have a new medical school, first medical school in how many years, Frank? About 20 years in Ontario? No, about 40 years, and it's going to be focused on primary care, and it's going to be focused on the diversity of the community that Frank represents in Brampton and Peel region. And I think it's actually a focus on exactly what you're talking about. That is education, that's generalist education, yeah. Yeah. And tell me, nurses, please, Frank, tell me they're going to be nurse practitioners with this being TMU? Terrific.
Thank you. Question here.
Yes, when my daughter was going through medical school about 11 years ago, she was at the end of medical school, being asked to choose her specialty for her residency. And she would be doing different clinics, and they'd say to her, oh, you should come into this one. And the next doctor, next specialty, oh, you should come into this one. And at the end, she said, no, I want to go into family medicine. And doctors turned to her after she'd made her decision and said, but you're so smart. Why do you want to go into family medicine? The other thing that came about was a lot of these young adults had big debts to pay. And if you went into family medicine, it was going to take you a long time to pay off those debts. But if you went into a specialty, you could pay them off faster. There was an incentive to go into the specialties. The other thing that she was faced with when she was going into medicine was they were reducing the number of positions in the medical schools. So it was harder to get in. Why are we reducing these spots when we were facing a crisis down the road? So I would just like to say I am 100% behind family doctors and primary care and what they need to do, and we need to support them. There was an excellent radio program by Brian Goldman talking to a doctor on Salt Spring Island. About 40% of his time is taken in doing administrative things. then fix the system. Get somebody else to do that for them or to help them with them. The family doctors want to be with their patients. They want to do the best quality work that they can do. But if we're not helping them get into the profession, support them in the profession, then we're going to be seeing them leave the profession. So, and I also liked what Dr. Drummond said about 10 provinces and territories having their own systems to fix the problem. What came about at this Vancouver conference was there were two things the feds brought forward to streamline things across Canada, and they were shot down because the premiers just wanted to ask for more money. It's ridiculous. Get your act together. Get some, figure out what we can do across Canada. I mean, you can't take liquor across provinces. You can't take staff across provinces. We got to fix this. I completely agree with Dr. Drummond's feelings about, little silos that we have. There's something that has to be done.
Thank you. Take another question before. Yes, question here, and then is there one here? Okay, one up there, and then you're next. Okay.
Thank you very much for your very salient presentations. As a patient that has been the victim of the medical system still using fax machines, although almost all other professions have ceased, but also as an economist and as a demographer, I have two issues that I haven't heard addressed yet today. First is the impact of us unable to use effectively the hundreds of thousands of skilled medical professionals, foreign medical professionals, that have been faced with either a all or nothing proposition in entry into the system in Canada. This is nurses, doctors, and other professionals, and is a debate that I have been watching for 40 years, and the ancient guild-like reactions of our medical associations, both nurses and doctors. And second, and this is a little more delicate, the cost impact of privacy legislation on preventing a patient to be effectively treated because they have to repeat their information. The lack of sharing of information within one hospital is a major cost item. And if anyone wants to sit down with me as a patient and as economist, I could document the tens of thousands of dollars per patient that this involves. How do we push back to allow practitioners within the one hospital who's serving a patient to share the information so the patient doesn't have to keep giving it and a nurse or another staffer doesn't have to keep taking down the same information? Looking forward to your responses. Thank you again. Very salient comments. And Dr. Bell, your comments about the nurse practitioners are particularly salient, but I know the debate started 30 years ago, and we've only just got them now. Thank you.
Thank you for your comment, and I will comment briefly. Credentialing, that whole issue is as old as I am, practically. And the second issue, I do recall in trips to the emergency room each time, because a patient who, even though they have their own oncologist, but while being treated, if they run into a problem, has to come in like a new patient, and you're giving the information to the triage nurse after several hours of waiting, and then literally touching her, and the next thing, you're repeating the exact same information. Is stunning. Next.
To build on what was stated, not only about credentialing individuals from outside of Canada, but how do we attract health human resources and inspire them to take this on as a profession? Because I'm hearing a lot about systems and infrastructure in your conversation, as well as culture, but we need people to provide the care.
Yeah, I think that's something that we've learned again through COVID, lessons learned through the pandemic, right? And that is the importance of creating health human resource strategies in this country that look at the opportunity for people to come into this country, as many healthcare providers do as immigrants, and to actually work their way up in the system. A lot of folks come here with training as nurses in the Philippines and India, for example, who work as personal support workers, who need the opportunity to become registered practical nurses and registered nurses. And right now, that's not really part of the trajectory that we discuss. And that's a real opportunity. I agree with the gentleman who talked about international graduates being an immediate opportunity, and I think to their credit, the government is responding to that, both in nursing and physicians, to try to increase the number of new foreign-trained graduates that can work here. But I think we need more than that. I agree with you. I think we need to say, come to this country. If you only qualify today to be a personal support worker, a healthcare aide, there is a way that you can expand your contribution and become a different player in our system with time.
What I'm going to do is take one last comment from the floor and then give each of you less than 60 seconds to sum up any comment you want to make, and then we'll have to, you want to speak also?
That's the last comment. Is there?
Well, I'm just, unless they give up their minute, maybe.
Me too.
Okay, you come on up. Okay, next.
I do want to, sorry, I do want to add that I came to this country 22 years ago from a very small country called Guyana. And I was a nurse back home, managed and emerged by myself. I came to this country, my qualifications were not recognized. I work as a personal support worker. I was fortunate to be with Camille at the Toronto Central LINS. I have also managed in the community, and fortunately, luckily, I'm the administrator of a long-term care home here in Toronto. And I do want to say that my road to healthcare has not been great, and Camille mentioned it. Being an immigrant in Canada, the healthcare does not represent us. And if you notice, most of us are healthcare workers. We care so much about our residents because we come with our passion. And we want to be heard. We want to be given a chance to show y'all how much we can contribute and how much we care. And in order for the healthcare system to generate a great change in nursing, etc., because I'm a nurse, 22 years I've been doing this, and my passion, I bleed healthcare. Listen to us. We have been working in here for quite some time. Half us at the table, yes, our accent and where we're from might not represent the majority here, but we have insights. We care passionately about our residents, and I have a family member in this audience that can attest to how passionate we are. Y'all think it's the money? That is not why we do it. We do it because we care. So we ask for a seat at the table so that we can express our desire to give you all the great care that you need.
I think we'll take one last comment from the audience rather than.
I've got more than one comment, but I'm going to try to
Thank
keep
you.
it to
Is
a
it
few.
the same?
I think this is, we'll all agree, this is a complex problem and there's no simple solution, right? So what are the solutions I've heard tonight? What are the solutions I've heard tonight? This is a complex problem with no simple solutions. And first of all, I really want to thank you for putting this on. I think it's wonderful to have this sort of debate and discussion. And if we do more of this, I think we'll come up with the solution to the problem. Okay. And so we need this sort of forum on, more than just once in a while. So what have I heard tonight? Well, I've heard about central access, and that's proven to be effective, especially in the MSK program. I've heard about episodes of care. I thought we were going to revamp our health and community care programs, and episodes of care never really got the traction I think it should have. Team-based care. Team-based care exists in Ontario, but not enough of it, especially in the inner cities and the suburbs. Transitional care. There we have a great opportunity, so those patients can get the proper care they need as opposed to lingering in acute care beds that are really blocking my emergency department and everyone else's. Rapid access nursing and removing perverse incentives so you can get people home. It's much easier for me to admit someone than to plan out their journey home and their care at home. And this is really something concerning. We have facilities that don't work 24/7. They seem to take a break on Friday afternoon. I can throw a bowling ball down my outpatient clinic on a Thursday evening or a Friday afternoon, there's no one there. We really need to make those 24/7 facilities. Building a future roadmap, because we know what kind of care we're going to need. In my community, cancer will double in 20 years, so I need an integrated cancer center. Home first. Really, it's about home first, and that's the mindset that needs to be there. That discharge planner needs to be in the emergency department and plan that home first for the patient. And then finally, we're not investing enough in prevention and upstream thinking. If we do that, that investment will reap benefits beyond belief. And finally, we really do need a coordinated, we need care managers in primary care, home and community care coordinators working with family doctors, as opposed to me making a phone call. That person is embedded in my practice. Just a few thoughts.
Well, thank you very much. Unfortunately, we are out of time. I do want to thank, first of all, Natalie, thank you for hosting and for making this possible. A shout out to Catherine Fowler, who put this together. And to this outstanding panel, it has been a privilege to meet, Bob I knew, but Shirley and Alan, to meet you. I think everyone here realizes what a privilege it has been to spend this time with you and to hear from you, national leaders in healthcare, really people who understand it best in the country. And finally, I want to thank you, everybody who's participated. I think that I'm part of a lot of different discussion groups, and I have to say, the level of engagement and the quality of discussion here tonight was very, very inspiring. So thank you very much for coming, for being part of this, and please stay engaged, because as several people said tonight, unless we all remain committed to this, we must not let inferior care become normalized. We cannot accept this, because if we give up, it will become normalized, and people, and I hear it said today, well, it's a public health care system, what do you expect? Huh? Well, if we take that attitude, we won't get more. So thank you all very, very much.